This is Unit 17. We're going to talk about blood cultures. Holla! Okay, stay tuned for Unit 17. The first thing I want to do is discuss the differences between bacteremia and septicemia. Okay, first of all, bacteremia is usually asymptomatic, where there's a showering of viable bacteria into the bloodstream. It may be transient, or the bug may be in the bloodstream for a short duration of time, and they may be intermittent or continuous. Sources of bacteremia would include dental procedures, catheterization, longer bone infections, and bacteria in the bloodstream are overtaken by the phagocytic cells and are quickly cleared by the body's immune system. If the bacterial multiplication exceeds the body's capacity to remove them, then septicemia develops. So septicemia is basically bacteremia with severe presentation and toxins noted. Persistent bacteremia has clinical symptoms, and those symptoms are fever, chills, malaise, tachycardia, which is fast or rapid heartbeat, hyperventilation. Some sources for people to become septic would be urinary tract infections that become septic, longer gastrointestinal infections, body lesions, surgical wounds, chronic disease, and IV contamination. Those are all sources of septicemia. Usually in the case of septicemia, bacteria multiply faster than they can be phagocytized by our second line of defense. Anytime a patient is septic, that really increases their risk of death, and that goes way up. That risk of death goes way up if septicemia is left untreated or inadequately treated. So if you're over the age of 50 and you have an untreated case of septicemia, you have a 49% chance of death. If the organism isolated is Enterococcus and it's untreated, you have a 46% chance of death. If it's Staphylococcus and it goes untreated, you have a 32% chance of death. The source of the infection can also contribute to morbidity and mortality. If you have a genitourinary source, you have a 15% chance of death. This actually accounts for 17% of all septicemias, is one that comes from the genitourinary source. Surgical wound sources, respiratory tract sources account for 12% of septicemias, and if you have a surgical wound or a respiratory tract infection that goes untreated, if you're septic, you have a 45% chance of death. If you have diabetes, cirrhosis of the liver, or cancer and you're septic, you have a 30% chance of death, a 72% chance of death, and a 42% chance of death, respectively. So you might be asking yourself, how does one actually become septic? And remember, sepsis is a systemic response to an infection, okay? If you have a skin puncture or direct inoculation or direct penetration, you can become septic from that. If the infection originated somewhere else in the body, you can become septic from that. So for example, you could have a urinary tract infection and then later become septic because of that. Or if your lymphatic system is infected, or if you have a bone infection, you can become septicemic because of that. If you have contaminated infusion materials, such as blood products that are contaminated or IV solutions that are contaminated, those are reasons why a person might become septic as well. Some sources of bacterial spread, things that actually spread bacteria around the body, would be pericarditis, which of course is an infection of the pericardium around the heart. Usually things that cause infections around the heart would be Staph aureus or Strep A. You can have peritonitis. 5% of all septicemias originate from enterics in the gut, and an explosion of those enterics into the gut during peritonitis. Pneumonia, the cause of pneumonia is usually Streptococcus pneumoniae. You can have pressure sores. Staphylococcus aureus is often the cause of pressure sores, and pressure sores account for 2% of all septicemias. Bone infections and prosthetic medical devices. Prosthetic medical devices, you could have infected catheters, infected shunts, or pacemakers. Those can all lead to bacterial spread. 50% of all septicemias originate from the bone. The capillaries in the bone are actually seeded with bacteria, and that's how a person becomes septicemic. Hip and knee replacements can also be the source of bacterial spread as well. Anytime we're doing blood cultures, we always want to reduce the risk of contaminants. And contaminants are usually organisms on the skin that contaminate your blood culture bottles. A contaminant is an organism that grows in blood cultures presumed to be from the patient's own skin and not associated with disease. Less than 3% of blood cultures should be contaminated, okay? So the other 97% should grow out the potential pathogen more than anything else. Now, sometimes the organisms on the skin can be a contaminant, and some common organisms that can be contaminants would be things like diphtheroids. Those are our gram-positive rods. Cutibacterium acnes, Bacillus species, and coag-negative staph. Those are all things on the skin, and when the skin is not decontaminated properly, this can contaminate the blood culture bottles. There are certainly a number of reasons why a physician might order blood cultures on a patient. If our patient has a fever of unknown origin, they might order blood cultures. If our patient has hypothermia or if they're experiencing chills with or without fever, blood cultures may be ordered. If they have leukocytosis or a high white cell count, and usually that's a white cell count greater than 10, that could lead to a physician ordering blood cultures. If our patient has granulocytopenia or a low number of mature granulocytes, this could lead to blood culture orders. If our patient is in shock, if they have nausea, vomiting, hypotension, or hyperventilation, these are all reasons why a physician might order blood cultures on our patient. In some situations, getting blood cultures is the only way we can diagnose our patient as being septicemic. In other cases, blood cultures may indicate the severity of a disease. For an example, you may have a urinary tract infection that has gone south and that has now led to septicemia. Also, urine cultures may grow the same organism as the patient's blood culture. I always found that to be very interesting. The patient is 3 to 5 times more likely to die if an antibiotic that is given in the case of blood cultures is ineffective. So it is important that we rapidly diagnose our patients as having septicemia. Also, we want to give the doctor as much knowledge as we can so they know what to expect if there's going to be any complications and things of that nature. Also, a proper diagnosis helps the doctor find the source of the infection. So in other words, did the septicemia originate from the urinary tract, or did septicemia originate from a person's pneumonia? And finally, diagnosis can help the doctor institute life-saving non-antibiotic support measures, such as giving the patient fluids or blood pressure medications. I want to talk a little bit about this very important hormone known as procalcitonin. Procalcitonin is a hormone that is involved with calcium homeostasis. A normal procalcitonin level is 0.01 micrograms per liter or less than that. Procalcitonin, this hormone will actually go up as inflammation from a bacterial source starts to ensue. If a patient's procalcitonin goes up, they usually have septicemia, and you can tell that by the number of blood culture bottles that are positive. 90% procalcitonin is 90% sensitive for patients that have septicemia, and that procalcitonin may actually rise significant in 6 hours after endotoxins are produced. Those are endotoxins associated with gram-negative organisms. This is long before CRP, or C-reactive protein, which is an acute phase reactant that goes up in inflammation. The sample of choice to test procalcitonin is plasma. So, a quick way to determine if somebody is positive for septicemia is by doing a procalcitonin level. If that procalcitonin is positive, they're most likely going to have positive blood cultures. So generally, we want to collect a number of blood cultures on each patient, okay? We want to determine if the patient really does have septicemia or just bacteremia. So we want to draw several blood culture bottles. The timing of the draw is also important since some agents of infection are in the blood intermittently and some are in the blood continuously. Okay, this rules out septicemia versus bacteremia. The number of cultures collected is less important than the total volume of blood cultured. The more blood collected, the more likely to rapidly grow out and identify infecting organisms. Some studies suggest collecting 30 mils of blood at a time to be used over several bottles. It is estimated that there's a 36% increase in number of organisms collected when collecting 30 mils of blood. Now, your book says to collect 20 mils of blood on adults, but this is changing. Ultimately and optimally, it is best to collect blood cultures before administration of antibiotics. In life-threatening circumstances, it's not unusual to have 2 or 3 sets of blood culture bottles drawn. And what I mean by a set is usually we have 1 anaerobic bottle and 1 aerobic bottle. That is considered a set. So sometimes up to 6 blood culture bottles can be drawn on one patient. 30 mils of blood is recommended for the collection on adults, although your book says 20 mils on adults is fine, but this is all changing now. Here's kind of some general guidelines when it comes to collecting blood culture bottles. Okay, if our patient has a fever of unknown origin, usually we're going to collect a set of blood culture bottles initially, and then 2 more sets 24 to 36 hours later. Okay, and remember, a set includes 1 bottle that's aerobic and 1 bottle that's anaerobic. If we suspect our patient has acute endocarditis, then we're going to collect blood cultures from 3 different venipuncture sites. And then standing blood cultures is not something we want to encourage or condone. That's when we just have a standing order for collecting blood cultures on patients that are not symptomatic, and that's really frowned upon. So the optimal amount of blood to collect for people that are greater than 10 years old would be 30 mils of blood. Children that are less than 10 years old, it is recommended that 1 mil of blood be collected for every year of their age. For example, 1 mil might be collected for a 1-year-old, 2 mils would be collected for a 2-year-old, etc. If you have a patient that's over 10 but they have poor veins, try to get the full 30 mils, but if you're unable to attain, go ahead and fill up the aerobic bottle first and put the remaining volume in the anaerobic bottle. Aerobic bottles will eventually grow out Bacteroides and Fusobacterium, which are both anaerobes. Both anaerobes are typical anaerobic causes of septicemia. Aerobes will not grow in an anaerobic bottle. Okay? Let's go ahead and talk about the proper collection of blood culture draws. The things that we're going to discuss are skin preparation, blood draw procedure, how to prep the bottles, and also the choice of bottles that we can choose from. Anytime we're collecting blood cultures, we want to wash that skin with soap and water and rinse it with sterile water. We want to clean the collection site with chlorhexidine and 70% alcohol or 10% iodine. If repalpation is necessary, then of course we need to re-disinfect that site of venipuncture. Okay? And again, you can clean it with 70% alcohol, but cleaning it with 80 to 95% ethanol is even better. When collecting the blood, it's really a good idea if you have access to a blood culture collection set to go ahead and use that. All supplies that are needed are included in the set. We can use a needle and a syringe method for difficult sticks. Consider changing the needle before entering the bottle. Vacutainer collection is appropriate in some circumstances, especially if we're going to collect blood for SPS tubes, which are for blood cultures, and that is a sodium polyanethol sulfonate tube. Always draw blood cultures below the catheter or line sites attached to the patient. We do have to prep our blood culture bottles as well. We want to wipe the blood culture bottles in the same manner as the skin is prepared. So we want to wipe the top with iodine, and it's not unusual for iodine step to be omitted, but sometimes people clean the top of the bottle with iodine and allow it to sit for a little bit. Then we can wipe that stopper with the alcohol and transfer blood into bottles using a safety transfer device. Never force blood into the bottles. You want to allow the blood to transfer to the bottle freely. There are a number of blood culture systems out there made by several manufacturers. The media, though, in general, is multi-purposed and nutritionally enriched. All commercial systems are slightly different from one another, but they are very similar to one another as well. Generally, blood culture media contains an anticoagulant, usually that's SPS or sodium polyanethol sulfonate. Usually that blood culture bottle contains a nutrient broth of some sort, and that could be several different types of nutrient broth. And also our blood culture bottles include antibiotic removing resins that may remove any antibiotic that was taken by our patient prior to the collection of blood culture bottles. Some common commercial systems that I'm going to talk about would be the Oxoid signal system, the Wampole isolator system, the BacT alert system, BacT 9120, 9240, and the Trek ESP system. We're going to talk about all of these commercial blood culture systems. Let's start by talking about the Oxoid signal system. This is the system we're going to use in our student laboratory. It is a single bottle system that detects CO2 in the bottle. It is a manual method where we don't put the bottle on an instrument of any kind. Instead, we are attaching a plastic tube and a chamber to the bottle itself via a long needle. If there's any growth in the blood culture bottle, CO2 is going to go up the needle bevel, and fluid is going to go up that needle and into the collection chamber. The fluid in the chamber can be gram stained and subsequently subcultured. This is a manual method where fluid in the chamber equals growth of the blood culture bottle. The Wampole Isostat is another way of collecting blood cultures. It is useful for the recovery of slow-growing fastidious organisms and molds. The system uses a lysis centrifugation method. So blood is collected in the tube and it's spun. White cells and red cells are then lysed and the sediment is then subcultured. A tube contains substances that lyse the white cells and the red cells, and it holds about 10 mils of blood. The tube is then centrifuged at an angle at 3000 RPMs for 15 minutes, and we take that sediment, aspirate it, and subculture it to the appropriate media. The next blood culture system I want to talk about is the BacT alert system. This is considered a continuous monitoring blood culture system because it is placed on an instrument, and that instrument checks for CO2 levels with a chemical sensor. There's a membrane at the bottom of the tube that actually senses a rise in CO2. When that CO2 rises, the membrane sensor changes color. The color of the sensor is monitored every 10 minutes on a machine via a reflecting light that goes through the membrane. If there are high levels of CO2 in the bottle then triggers the sensor, which responds to the light, and the tech is alerted that the bottle is positive. Okay. The membrane is pH sensitive, which contributes to the sensor noticing a color change. This is not using fluorescent light of any kind. The BacT 9240, 9120 system is similar to the BacT alert system. The BacT system is larger and holds either 120 or 240 bottles in a self-contained incubator, agitator, and detection cabinet. Another difference is the light used is fluorescent light instead of spectral light. Fluorescent light patterns influence voltage, and a delta failure indicates CO2 and growth. So in the BacT 9120 or 9240 system, fluorescent light passes through the bottle's bottom, and we look for a voltage change. If there is a voltage change, we can determine from that there is CO2 or growth in the bottle. The Trek ESP system looks for CO2 in the system, but it also looks for hydrogen and oxygen gas as well. Gas consumption and production here are both monitored, and changes in the concentration of hydrogen and oxygen in addition to CO2 are detected. This system actually reads a change in air pressure. DIFCO has a similar system, but in their system they look at nitrogen gas instead of hydrogen gas. There is a theoretical advantage to this system because it looks at two markers determining bacterial growth. And then we have an image of different blood culture bottle types. So we can see on the very left, we have what's known as the Trek or DIFCO. They're kind of the short, squatty looking blood culture bottles. In the middle, we have the BacT 9240 40 bottles, right in the middle, the tall, skinny bottles. And then the little square bottles on the right would be considered the AccuMed system. And then on the very right, we have the BacT alert bottles. So you can see different manufacturers have different bottle shapes. Media inside the blood culture bottle is usually an all-purpose and nutritionally enriched media. We can see lots of different types of medias, including tryptic or trypticase soy broth, which is rich in amino acids, glucose, and sodium chloride. We may also have blood culture bottles that have brain-heart infusion broth, which is good for fastidious organisms or anaerobes because it has hemin and vitamin K. We may also use a Brucella broth. Brucella broth is good for Brucella and fastidious organisms because it is rich in nitrogen and carbon and also dextrose. We could also see blood culture bottles that have Colombian CNA broth, which is enriched and selective for gram-positives. And then another blood culture media that you could see would be supplemented peptone broth. There's a number of specific ingredients in the blood culture media. The first one I want to mention are the anticoagulants, and that could be SPS, SAS, or PABA, but the most common is sodium polyanethyl sulfonate, which is SPS. It is the most common and prevents clots. It inactivates leukocytes, and it also inactivates aminoglycosides. Other substances that we may see in the media of blood culture bottles would be antibiotic-reducing resins, L-cysteine, which is a compound that maintains low oxygen for anaerobes. We could have hemin and vitamin K in the bottle, which is good for anaerobes. We can have sucrose in the bottle, and sucrose is going to increase the growth of what we call L forms. These are bacteria that lyse easily, which is why they are called L forms. And then our blood culture bottle may also contain its own source of 3 to 10% carbon dioxide in the bottle for the growth of capnophilic bugs. So how do we incubate those bottles? Aerobic bottles have to be vented for aerobes, and anaerobic bottles must not be vented. Also, capnophilic bottles, we don't want to let the CO2 out of the bottles that contain CO2. Typically, we incubate our blood culture bottles for 7 days, and that's for routine cultures. If you have a blood culture request where we're looking for Brucella or Listeria, then we want to hold those bottles for 3 weeks or 21 days. Okay, Brucella causes what's known as brucellosis. These are tiny gram-negative cocci. They are an occupational hazard associated with diseases of farmers and veterinarians. People that have Brucella have fever, chills, weight loss, fatigue, depression, and muscle aches. People that have Listeria, and Listeria is a gram-positive rod, this organism can cause different things like food poisoning. It can actually go from mom to baby and cause meningitis in the baby. So anytime we're looking for Brucella or Listeria, we want to hold those blood culture bottles for 21 days because Brucella and Listeria are slow growers. If you have a patient that's on antibiotic therapy at the time of blood culture bottle collection, then we do want to hold those bottles for a minimum of 14 days. As a microbiologist, there's some other helpful information that you could find to be important when dealing with blood culture bottles. For example, you might want to know the suspected diagnosis of the patient. You might want to know the severity of the infection, and then you definitely want to know the timing, dose, and type of antibiotic being used, because if you're trying to grow out an organism that's been affected by antibiotics, it may be a little gorked out and hard to work with. Metabolically, it might be a little inert. Sometimes you can tell a bottle is growing by manually inspecting the bottle. Bottles that are not incubated on an instrument has to be visually inspected twice a day. There's a number of things that would indicate that you have growth in the bottle. Now, when you're inspecting these bottles, don't mix, tip, or shake the bottles. Instead, we want to look for evidence of growth. For example, we want to look for heavy turbidity across the cell line, and any organism can actually cause turbidity in the blood culture bottle. We want to look for jelly-like masses in the bottle. Staphylococcus can sometimes do that. We want to look for cotton ball colonies throughout the bottle. Anytime you have streppy looking puff balls, you're going to notice that in a blood culture bottle. Also, other things like pellicles or scum on the surface of the cells could indicate that you have yeast or mold in the bottle. If you have large amounts of gas or CO2 production, this could be any organism that is causing this bottle to be bubbly, but especially Clostridium and Klebsiella can cause a lot of gas production in your blood culture bottle. So once you have a blood culture bottle that appears to be positive, there is a number of steps that we need to do to process those blood culture bottles. First of all, we want to aspirate the material with a sterile needle and syringe without removing the rubber stopper on the broth, or the broth from the indicator chamber using the Oxoid method. Okay, we want the stopper on the blood culture bottle to be sterilized and decontaminated with alcohol first. Then we're going to prepare a gram stain. Okay, we want to use sterile or at least clean slides to do this. The gram stain, once we've viewed it, will determine the proper media for subculture. Okay, now keep in mind, anytime you're trying to gram stain a thick bloody smear, it does require a longer decolorization step. Okay, determine what media and atmosphere to set based on what's seen. For example, if you are gram staining a aerobic bottle and you see gram-positive cocci, you're probably going to subculture to a blood agar plate. If you're staining an anaerobic bottle and you see a gram-negative rod, then you're probably going to set up an anaerobic blood agar plate. If you have an aerobic bottle that has a gram-negative rod, you're probably going to set up a blood agar plate and a MAC, and then maybe a chocolate. So what you see on the gram stain helps you determine which media you're going to set. Okay, you want to inoculate the plate media and incubate those appropriately, and then set sensitivity and ID schemes. So here you can set coags, microscans. Some of these things can be set right from the bottle or directly from the bottle. So for example, if you see a gram-positive cocci that looks like staph on your gram stain, you can actually go ahead and set up a coag right from the blood culture bottle. Then you want to call all results all along the way to the physicians as you are processing these blood culture bottles. So as soon as they go positive, we want to call those to the physician right away. This can be a life-threatening type of concern. Anytime we're dealing with blood culture bottles, we want to determine how significant it is that it went positive. So first of all, we want to consider the number of bottles growing. So for example, if you had 6 bottles drawn on one patient and only one of the 6 bottles were growing, it's probably a contaminant. If you have 5 out of the 6 bottles growing, most likely it's significant. All results should be reported to the physician. Don't decide if the organism is a contaminant or significant. Either way, we're going to call it to the physician. So like I said, anytime we have positive cultures, this has to be relayed to the appropriate parties. We have to call the results, and then we have to follow that up with a written report. And then we want to save our isolates for a long period of time, or until the physician says we can get rid of the bottles, because we want to have those in case the physician decides to order more susceptibility testing on that isolate. Positive blood culture bottles have to be saved for 1 year, while negative blood culture bottles are only saved for 30 days. It is possible to have a positive blood culture. You could have a patient that has septicemia, but they still have negative blood cultures, and you might be asking yourself, well, how can that happen? You can have poor culture technique. In other words, we subbed it to the improper media, or we incubated it improperly. So it could be some technical reason why we were not able to grow out the organism causing their septicemia. If our patient used antimicrobials prior to them having blood cultures collected on them, the bugs in the blood are not too viable at this point because of antibiotic treatment, and you may not be able to get them to grow at all. You could have the presence of L forms, and L forms are organisms that lyse easily, so you're unable to grow them out. You could have, or your patient could have, right-sided endocarditis, where the lungs filter out the bacteria. Even though they are septic, the lungs are actually filtering out that bacteria. And if your patient has renal disease, it's possible that the kidneys are filtering the blood as well. Now keep in mind, patients have certain chemicals in their own blood that resist becoming septic. And those substances in our own blood would be things like antibodies, phagocytes, and lysozyme. Those are just a few chemicals in our own blood that makes our blood resistant to infection. There are certain things we do not want to do when dealing with blood cultures. One thing is we don't want to use bottles or plates that contain citrates or oxalates as the anticoagulant. These anticoagulants actually inhibit bacterial growth by chelating calcium. So sodium citrate in vacuum are not good for blood cultures because they will chelate calcium. We want to not fail to perform blind subcultures. So in other words, what that means is the machine indicates that the bottle is positive, but our own gram stain sees nothing. We still need to subculture it. Maybe they're acid-fast bacillus, maybe there's something else, but maybe there's only a few bugs and we can't get them to grow. But we still definitely want to sub bottles even if we don't see anything growing on the gram stain. We also want to make sure to not remove the cap on a blood culture bottle. We don't want oxygen to get in the case of anaerobic bottles, and we don't want CO2 to escape in the case of capnophilic bottles. Okay? And then another issue we may have is using only anaerobic bottles. Our anaerobes will grow in the aerobic bottle, but our aerobes will not grow in an anaerobic bottle. Now, any organism could cause septicemia, but this list is the common ones that cause septicemia. So out of our aerobic gram-negative rods, you can see that E. coli, Klebsiella, Enterobacter, Serratia, Proteus, and Pseudomonas are all on the list. Some organisms that can be the cause of anaerobic septicemia would be Bacteroides fragilis, Fusobacterium, Clostridium species, and Peptostreptococcus. And like I said, virtually any organism can cause positive blood cultures, but here is a list of some other ones. Pneumococcus, which is Streptococcus pneumoniae, Streptococcus, especially alpha streps from dental procedures, Staphylococcus, especially Staphylococcus epidermidis from endocarditis, Neisseria species. Let's say our patient has meningitis from Neisseria meningitidis. That Neisseria meningitidis can now get in their blood. Let's say our patient has Haemophilus from endocarditis. It is possible that Haemophilus parainfluenza can also cause positive blood cultures. Now, sometimes contaminated infusions can be the source of septicemia. These are fluids that are injected into the patient, such as blood products or IV fluids. Remember, Yersinia is one of the organisms that actually can contaminate blood products and IV fluids because it loves the cooler temperatures that those products are stored in. If a person has septicemia that came from a contaminated infusion, that's pretty much indistinguishable from other forms of septicemia. Our patients still have fever, chills, tachycardia, and things like that. They still have the same symptoms. Infusion-related isolates should be identified to the species level. So even if we have an infusion-related isolate, we still need to identify that bug all the way down to the species level. We do want to perform a complete susceptibility test, and we're going to save our isolates for a year. And most microbiology labs should be able to or should be capable of culturing infusion fluids, IV medications, infusion cannulas, and other environmental specimens. Now, blood products can actually be contaminated during the processing of blood components at the hospital or the blood bank. So when a blood culture bag is collected, usually that's spun down in a centrifuge, and the serum is actually taken away from the red cells. Okay, or actually that would be plasma that's taken away from the red cells, and the platelets are also removed as well. But anytime that they are processing blood culture bags, they use what's known as a heat sealing device because they're making segments or segs in the component laboratory. The tube can actually melt, and that can cause our blood bag to get contaminated. It's pretty scary to understand that 1 in 3,000 blood products are bacterially contaminated. You're way more likely to have septicemia from getting a blood bag or a blood transfusion than you are to catch a viral disease like HIV or hepatitis. As you can see there, statistically, 30 million units are transfused a year and only 1 in 5 million have a chance of getting HIV, but only 1 in 3,000 has a chance of giving you a bacterial contaminant. Platelets are stored at room temperature, and so they're the most likely blood component to be contaminated. And red cell contaminants are usually Yersinia intercolitica or Pseudomonas. It's got to be, or Serratia liquefaciens. These are all organisms that can appreciate lower temperatures. Even Listeria can be the cause of bacterial blood product contaminants. Finally, the last thing you need to understand is how to culture a blood transfusion cannula, which you may be called upon to do if your patient has a transfusion reaction right after blood products have been infused. So here we want to use sterile technique and take that cannula and roll it back and forth across a blood agar plate at least 4 times. Here we're going to use sterilized and cooled forceps. We want to incubate that plate aerobically at 35 degrees for 72 hours. If after 72 hours there are 15 colonies or more on the plate, this indicates that the cannula has bacterial contamination or contamination of the blood product. All right, that's it for Unit 20, our blood cultures. We will be moving on to Unit 21 here shortly.